Hello, welcome back. Didn't expect to see me again, right? I passed my USMLE Step 1 and now I'm entering my clinical clerkships, and my first rotation is in psychiatry. So, in this presentation, I'm going to go over the shelf exams and what the topics would be entailing. So, in order to get to your clinical clerkships, you have to pass step 1. And there really isn't any secret to success besides putting in the work. It's just constant repetition, constant practice questions. Knowing the basics and the foundation is much more important than knowing the minutiae. So the two resources I used were either Amboss or UWorld, and you can go back and forth between the two of them all you want. I used both, and in my opinion, they're pretty comparable. If you can afford it, I do recommend doing both because Amboss has a better library, so you can look things up and get reliable results instead of just searching through Google. And UWorld is just a huge question bank. To me, the question caliber were basically the same. They were very similar to the USMLE when I took it. And I guess the one thing to consider is price. Amboss is cheaper. But hopefully you have also passed the USMLE and then you're going to join me in our rotations. So just starting out with the NBME breakdown, as you can see here, the big chunk of it will be behavioral health. The rest are things that we should keep in mind, but the main focus should be these topics in behavioral health. So that would include everything from anxiety, mood disorders, to eating and impulse control, to childhood disorders, to the substance abuse disorders, and adverse drug effects. Pharmacology is a big part of psychiatry, as we will go through, because there's a lot of medication with very serious side effects. So let's jump straight into it and begin with conditioning. So nobody's going to ask you about classical conditioning, but if you need a refresher, classical conditioning is Pavlov. Remember, you're using the bell and you're eliciting a involuntary response. So that's not quite as useful to us because in psychiatry we use operant conditioning. Not just operant conditioning; it's more refined now. But the importance of operant conditioning is that we use voluntary responses to target behaviors, whether to modify them, to encourage or decrease them. So to encourage a behavior, we use reinforcement. To decrease a behavior, we use punishment. And of course, without practice, there is extinction. So we have to keep in mind the different kinds of punishment. Remember, there's positive punishment and negative punishment. Positive punishment is giving a punishment in order to stop a behavior, such as when a child curses, you wash their mouth out with soap every single time. So they know that if they curse, they're going to get a mouthful of soap. They're not going to want to do it. So that stops the behavior. Negative punishment is taking something away and to discourage the behavior. So this is grounding. A child curses, you take away their PS5. That means they're really spoiled, but their phone or whatever away, right, for X amount of days in order to stop that behavior. But all of these are prone to extinction without constant reinforcement. And that doesn't mean just like reinforcement as in giving rewards. You have to be very consistent with these. And so moving on to projection and ego defenses. Transference is involving the patient. So the patient will transfer their emotions. They will project whatever on the physician. So say the patient is being verbally abused at home. So they feel belittled. So in order to relieve that feeling inside, they will go and belittle the nurse that's trying to take care of them. Countertransference is when the physician projects onto the patient. So, say I am a pediatric psychiatrist and my patient is a little girl that is being, sexually abused by her father. And let's say I had a similar background. So, I used to be abused by a relative or whatever. And then I will project, my empathy on the patient. So, it sounds a little bit counterintuitive because we as patients need to show empathy and compassion, but at the same time, this is a negative behavior once it starts compromising our judgment. It starts compromising our ability to teach, or to not teach, but to educate the patient and to treat the patient objectively, which sounds cold, but the best way to treat a patient is to see the problem, whether it be social, cultural, economic, medical, from all angles. And it's hard to, especially when there's something as strong as a connection, a bond because of like past sexual abuse that will blind you. So in that case, like the physician might offer to let the child stay at her home instead of calling CPS. So this is not necessarily a good thing as physicians. So ego defenses, they are the practices where you as the individual tries to alleviate the cognitive dissonance. So there are the immature and then the mature ways of defending your ego, right? The immature, of course, is acting out. So this is when a child throws a tantrum, or, some adults throw a tantrum, have a hissy fit in public. Denial, everybody knows what that means. Displacement is a bit more nuanced. Displacement is kind of a projection in a way. But this can be this is to another more neutral source. So, say the patient has been having a hard time at work, their boss yells at them, but they would never dare to yell at me, the physician, seeing them, right? So, let's say I'm seeing their son, right? So, the patient will be, or the patient's father, who is being yelled at by his boss, is belittling his son in front of me, even though he really wants to be yelling at me, the physician, because he may believe that I am not treating his son right, but all of that stems because he's being really frustrated by his job. It's a little convoluted, but I hope that makes sense. Dissociation is also a maladaptive or immature defense. So the patient will just completely dissociate from the situation. They're not going to try to resolve it. They're not going to try to face it head on or anything. They're just going to completely remove themselves away from the situation. Fixation, of course, is not a good thing. Will lead to rage, could lead to acting out, could lead to displacement. So all of these actually play very well together. You don't have to have one or the other. These all might coexist. Idealization is you might put somebody on a pedestal in order to kind of like take the responsibility off your shoulders. Identification is also kind of like trying to identify with an authority figure, trying to identify with somebody that you hold in esteem, to also put all of the responsibility on that person. And that could be like, okay, so I'm a third year medical student. I really, let's say, respect my boss and also don't really want to work that hard. So I will start copying the way my attending wears his stethoscope, right? So he might wear it on the left, I might wear it on the right, but I want to identify with him, so I start wearing it on the left too. Intellectualism is the way you just try to not rationalize, but you want to try to logic your way out of the problem. This is also a way to avoid self-blame. So be like, oh, well, this messed up. The tower fell down because of gravity, and gravity is pulling on the beams, and the beams are made out of wood, which is not as strong as steel. But the real problem was like you, the architect, may have miscalculated. Isolation of affect is kind of similar to dissociation, but this kind of takes away all responsibility. It's not just kind of like dissociating from the situation. This is isolating the thoughts, words, action of the patient to just basically avoid like self-blame. Passive aggression, we all know and have experienced this. Projection, there are all those different forms. Rationalization is a sort of way of intellectualism, but it's like your rationality. You're not using like science or logic. You're using your own science, you're using your own logic. So it might be pretty faulty, especially when the patient is trying to like rationalize their cocaine addiction. They're not using intellectualism, they're using their own rationale. Reaction formation is a weird and kind of tricky subject to explain. I think examples are better. So one example is a politician is closeted, yet he pushes he's closeted and is homosexual. He hasn't come out to his constituents. So in response to that cognitive dissonance, he pushes very, very conservative, very anti-gay rhetoric and like principles. Sorry, I'm not a lawmaker. I'm just studying to be a physician. But he pushes those things that are very against his own lifestyle. So that is reaction formation. Regression usually is going back to like temper tantrums or habits that people have grown out of. So this might be like biting your fingernails or turning back to being, I don't know, mean to your coworkers because when you were stressed, you were mean as a child and you grew out of it, but now you're going back to it because you're under a lot more stress. Repression is just to kind of like smother it all away, right? You're not going to remember anything. You're not going to remember the cause. You're not going to remember what you did. You're just going to repress it. And then splitting is very much associated with bipolar. It's either you're good or you're bad. No in between. They either love you as the physician or they want to sue you for everything. So the mature ego defense would be sublimation, which is to turn the unwanted impulse into something that is, socially acceptable. One of the major examples is somebody with a lot of, aggression, a lot of anger issues. They turn to using that anger in contact sports or like, martial arts or one of those kind of like aggressive type of sports in order to channel their aggression instead of acting out. Altruism is, doing the best for people without any major or visible rewards, like, physical, material rewards for you, the person doing things. Suppression is sort of similar to repression, but it's temporary. So suppression would be like, okay, so things are kind of falling down around me right now. My relationship isn't doing very well. I got bills to pay, but I'm taking the shelf tomorrow. I'm gonna have to like smother all of those for the time being so I can concentrate on one thing at a time. And then the last, of course, is humor. Okay, so moving on to grief, there is the Kubler-Ross model. This is the most popular or the most well-known model. Of course, it's denial, anger, bargaining, depression, and acceptance. And it usually lasts from 6 months to a year in normal grief. So a red herring that they do like to throw in is that auditory or visual hallucinations can be normal. This does not mean that this person is starting to get depression with psychotic features. This person doesn't necessarily have the complex bereavement. We'll go through that next. But once again, it is abnormal if it continues for more than 6 months and if it is really impeding in normal tasks, like normal everyday life. The other model of grief is the 4 phases. And this one is a bit more useful because we use it to diagnose the complex bereavement disorder. So, in the 4 phases of grief, it's shock, numbness, yearning, disorganization. So, this is where life is basically put on hold. It doesn't necessarily mean it's in shambles. This person may be able to go about day-to-day life, but they are significantly impaired to before the loss has occurred. And then the last, of course, would be reorganization. So the 4-phase grief model is used to diagnose persistent complex bereavement disorder. So it is a severe, like very, very severe grieving and functional impairment. It lasts for more than a year in adults and 6 months in children. And there are 5 criteria. So, of course, the first criteria is the death of a loved one or somebody close. So it could be a coworker or somebody that you see on the daily basis. It has a big effect. Criteria B is the yearning, the longing, but the most important definition would be the preoccupation with the deceased and the circumstances of the death. So this person will relive that situation over and over and over and over again. Usually this is when this is more common in things like accidents, so people will constantly relive that circumstance and try to process it in a way. It was like, what could I have done differently? Like, if I was fast enough, could I have saved them? So this is going to cause a significant amount of distress. And that would be criteria C, the reactive distress. So they would be not just longing for the deceased one. They could be hallucinating and saying like, oh, this person's right here. They could be denying that the death even occurred. They can be planning to join the person in death. There's a lot, but this is beyond normal grief. This is beyond just normal sadness, longing, feelings of emptiness. This is something that causes the criteria D, the functional impairment. So this person can hardly even go to the grocery store without breaking down. This person can't even cook without seeing their loved ones and just not being able to eat because they can't live on without their loved ones. So all of this will end up in grief and functional impairment that goes beyond social cultural norms. That's very important because in certain cultures, like my culture, I'm Vietnamese, one of the basically tests of whether you really loved a parent or not is to throw yourself in an open grave. So that's pretty normal in Vietnam, like true Vietnamese funerals are pretty wild. But here in the West, we don't do that. We see that very strange, right? So we might consider somebody having like PCRB or PCBD when it could just be social cultural. Another example are Filipinos. So they have a tradition where the body of the deceased loved one stays in the home for I want to say a month. If I'm wrong, please correct me. And they will treat that body as if the person is still alive. For us in the West, we find that honestly a bit like unnerving, but that is not our culture. So we have to keep in mind of other social cultural norms. So just to conclude, the Psych's protocol has to be honestly considered whenever we're giving kind of like grief advice or end-of-life counseling. So first, of course, is the setting. You want to be in a private setting. Since we're in the hospital, most of the time, we do want to kind of like close the doors, close the curtains, kind of dismiss any tech or nurse that isn't your chaperone around in order to have a conversation with the patient. So you do have to talk to the family and see what the family and the patient know, what they think is happening. Honestly, if all of this happens, you start going into a private room, you start dismissing people. They know what's up. So the invitation, of course, is there. Ask your patient what they want to know, but like kind of read the room too. If they kind of are like nervous and they know that this is bad news, you don't really want to say like, hey, do you want to know if you're going to die or not? No, use some tact. uh, of course, explain the disease, see what they know about the disease, and then respond appropriately. In some people do want you to, like, hold them and hold their hands and give them a hug. That may or may not be appropriate, so keep that in mind, especially if you are a male doctor. It's not appropriate to be, holding a female patient close, especially if they're young. You want to, it's a fine and tricky line. You want to be there, you want to be in a comfortable distance, but you can't overstep the boundary of being, first and foremost, their physician. So the summarizing is always the tough part because, they have just gone through all of this emotional dump, info dump. You don't have to summarize right then and there. Give them the time to process. That's what my attending tells me. Give them the time to process. Stay with them for as long as they need. You don't have to hold them, but they would like you to just be in the room and to reassure them. Give them time, come back later, and then decide on your next plan of action. So that's it for now. The next part will be the childhood disorders. It's a pretty long and lengthy one, but welcome back. I'm glad I'm here, and I hope you're here too. I can't wait to continue the rest of my medical journey with the rest of you. All right, bye bye for now.